This lecture is on disorders of white blood cells. There'll be 6 parts to this. This is part 1. There are my websites where I do questions with Dr. Hughes. Twitter, I'll be active again here relatively soon. And once again, I'm a forensic pathologist, but I have a really strong interest in general pathology and teaching medical students. If you would, or please, you have to read my disclaimers first. Make sure that you agree with them. If not, please stop viewing the lecture. Third disclaimer, and then also, in case you want to know about my teaching style, just watch the introductory lecture. Here are the references that I used. Many of these are just excellent. They're all excellent. A lot of them I wish I had in medical school. One's Guiding for Differential Diagnosis and that. I'd also like to say thank you to the University of North Dakota's Department of Medical Laboratory Science. As a forensic pathologist, I don't have much access to hemopath type stuff, just occasional tumors and that. They have a fantastic collection of slides there, and they allowed me to photograph them all. So my lectures always start with a question. So I don't expect you to know the answer to it. It's supposed to come from the lecture. It's a way to pay attention to the lecture. It guides you. It's a good way of increasing retention during the lecture. So just pause, try and answer it, and then we'll answer it at the end. And then for this one, I'm doing 2 questions. Okay, so we'll just start with non-neoplastic disorders. First of all, and some of these are general terms that can apply to neoplastic disorders as well, because obviously with leukopenia being a decreased number of white blood cells, but you see that you can see it with HIV, you can see it with immunodeficiency type diseases, but you can also see it with neoplastic disorders. I mean, when you have infiltration of the bone marrow by a leukemic clonal population, it's going to wipe out the normal cells that are there. So specifically, we'll talk about neutropenia or agranulocytosis. It says neutropenia is a decreased number of neutrophils, and agranulocytosis is an absence or near absence of neutrophils. Neutropenia is decreased, and A, remember, is none, like aplasia is no organ. Mechanism, it can be either due to decreased production of neutrophils, which can occur to a variety of things. If you have replacement of the bone marrow, as I just said, if you have a leukemic infiltrate, a lymphomatous infiltrate, a neoplastic, otherwise non-hematologic infiltrate that wipes out the normal bone marrow, then you will lose the ability to produce the hematopoietic cells. Or if you suppress their production, as a lot of drugs can do, that can cause neutropenia. You can also have increased destruction. That could be immune mediated, or you could have some type of overwhelming infection that damages the white blood cells or just uses them up. And I remember when I was at UT Southwestern, we would see meningitis, and you would see an inflammatory infiltrate that almost looked lymphocytic, but it wasn't. They were all just very immature neutrophils. And the reason being is that when the person is really, really sick, they have depleted their supply of mature neutrophils, and so they're just putting out everything that they can to try and fight that infection. And then sequestration in the spleen, as you talk about anemia, it can sequester red blood cells, but it can sequester white blood cells as well too, and that can cause a decreased number that are circulating in the blood. And this can obviously lead to infections, and it says common infections actually affect the oral cavity, but could involve other areas as well. It's listed skin, GI tract, the genitoanal region of the skin specifically. So for the opposite, not leukopenia, but leukocytosis is an increase in number of white blood cells. And so various types, you can have neutrophilic leukocytosis, which is most commonly associated with bacterial infections, but also tissue necrosis. Remember, when you have coagulative necrosis, the first reaction to it are the neutrophils, and they react to the dead tissue. So they're not just reacting to bacteria and that, but also dead tissue, and remove that. Eosinophilic leukocytosis, allergies, drugs, parasites, some of the main ones. Basophilic leukocytosis, the main one is in CML, chronic myelogenous leukemia. Monocytosis are usually more chronic infections. You can see them also in some of the autoimmune disorders. Lymphocytosis, associated with viral. And then one pathology that you'll see, and this would be in the neutrophils mostly, as far as I know, but you can see toxic granules. So in mature neutrophils, usually do not see the granulation. When you start seeing it, that'd be what would be the toxic granulation, and you can see that when they're increased in number and when they're responding to an infection. And then Dolly bodies are these kind of semi-ill-defined smudged blue areas in the cytoplasm. So I like to put these in just to make you think as we're going. So by what general mechanisms might a reactive leukocytosis occur? So think about it. Why would I get more white blood cells out in the flow of blood? So you have increased production. That'd be one way. You could have increased release from the bone marrow, as I just talked about with meningitis, where it's just putting out whatever it can to fight that infection. If you have decreased margination, which it says occurs in exercise, or decreased extravasation spread into tissues, would increase the number that are going to be in the circulating blood. So these are all ways that would increase the number that are going to be in the circulating blood. I'll talk about before, but I put it here twice because I think it's kind of an important differential. But you can have a really, really, really high level of white blood cells, of reactive white blood cells, and what they term a leukemoid reaction. The thing is, it can look like a leukemia because you're getting really, really high numbers of white blood cells. So you have to distinguish a leukemoid reaction, which is non-neoplastic, from a leukemia, which is neoplastic. And my next slide will go through that kind of way to do that. So the bottom right, I mentioned it, but there's a neutrophil. It's kind of immature, but you can see the granules very clearly. So that'd be toxic granulation. And then the little blue areas you see, like I said, to me, I've seen them on slides multiple times. I'm just trying to get good pictures of them and everything like that. But they're kind of ill-defined, these little blue cytoplasmic areas. Those are Dolly bodies. So like I said, you need to distinguish between a leukemoid reaction and chronic myelogenous leukemia. Usually the reactive neutrophilia won't have as high of a white blood cell count as a chronic myelogenous leukemia. And we'll talk about chronic myelogenous leukemia in a following lecture, but you see more mature forms in that. And you can see more immature forms in a reactive one. That's why they could overlap. But you would see basophilia in CML, but not in a reactive neutrophilia. You can see splenomegaly in CML, very characteristic of it, but you wouldn't see that in a reactive neutrophilia. Increased leukocyte alkaline phosphatase you would see in a reactive neutrophilic response, but not in chronic myelogenous leukemia. So remember, in a leukemoid reaction, they're still fairly normal. They may be a little bit immature, but they're normal. And so they would put out normal stuff like leukocyte alkaline phosphatase. You would see the toxic granulations in the Dolly bodies. You would not see the Philadelphia chromosome, but you would see that in CML. And you would see a left shift in both, but you would see blasts potentially in chronic myelogenous leukemia, but you're not going to see them in a reactive neutrophilic response. So one classic leukocytosis is infectious mononucleosis. The clinical features you see: fever, sore throat, lymphadenopathy, and it's spread through direct oral contact. So when I was growing up, they always called this truly the kissing disease. The etiology, it's usually Epstein-Barr virus, but it can also occur with cytomegalovirus. Pathology, as we're talking about, it's a leukocytosis, and they specifically have atypical lymphocytes. Most lymphocytes are high in C ratio, very little cytoplasm. These have more abundant cytoplasm, and it looks like they're reaching out and grabbing red blood cells around them. It's kind of the way I remember them. You see lymphadenopathy, and you can see splenomegaly, which can rupture. So individuals could die with infectious mono. I haven't had that happen as a forensic pathologist, but it's possible. And they can develop liver disease. Laboratory testing-wise, you'll see a positive heterophil reaction, which is the monospot test, and you can do EBV titers. So these are atypical lymphocytes. So you can see that the lymphocytes have a fairly abundant amount of cytoplasm. You can actually see it, whereas you don't see it normally. And then, like I said, it looks to me like they're holding on to the surrounding red blood cells. And I've always used that. I think somebody explained that to me that way, and it kind of just stuck in my mind. So lymph nodes can also be reactive. They can be acutely reactive or chronically reactive. In acute reaction, you're going to see really prominent germinal centers. You're going to see mitotic figures. And just remember, that's kind of the reactive part of it seems like that's the reactive part of it. So that's what's responding to the infection. Whereas if it's more chronic, you're just going to see more hyperplasia. So it can be follicular. You'll see increased follicles, pericortical, and then also occasionally sinus histiocytosis, where you see increased numbers of macrophages in the sinuses. So here too, the top left is actually from a spleen, but it just shows a very prominent germinal center with a lot of activity, which is what you'd see in acute reaction. And to the right is follicular hyperplasia. So an important differential, because follicular hyperplasia is a chronic process, can cause lymph nodes to enlarge. It can also look like follicular lymphoma. So it's always important differential diagnosis. Usually in follicular hyperplasia, you'll see germinal centers of varying size, whereas in follicular lymphoma, they tend to be all relatively the same size. And also follicular lymphoma is a neoplastic process and will efface the architecture of the lymph node, whereas follicular hyperplasia is just an abundant normal process and shouldn't. My mom actually sent this to me. I'm from the northwest corner of Montana, from Libby, Montana, and this is just where my mom lives. This is the backyard, just some deer wandering through. So, cat scratch disease. This is due to Bartonella henselae. Occurs 2 weeks after a cat scratch, or it says it can occur also after some other type of scratch. So, example, thorns. So, I would assume people potentially rose gardens, things like that. Most of them who get this are under the age of 18. And as we're talking about, you see lymphadenopathy. It says most often the neck or axilla, and it can last for 2 to 4 months. So kind of a chronic process. The characteristic feature are you see granulomas, and these can progress to necrotizing granulomas. And then one more condition, hemophagocytic lymphohistiocytosis. So hemophagocytic means they engulf hematopoietic cells, and it's kind of proliferation of, lymphocytes and macrophages. It's due to the widespread activation of CD8 positive T cells and macrophages, and then those macrophages engulf hematopoietic cells, hence the name hemophagocytic, and they release cytokines that inhibit hematopoiesis, and that leads to cytopenias. So if you inhibit the development of the red blood cells, white blood cells, you're going to get cytopenias, and it pretty serious, can lead to a shock-like clinical picture. It's usually initiated by EBV. My thought is that if you have a virus listed and you're not certain, EBV is always a good choice. It seems like you get fever, hematosplenomegaly. It seems oftentimes when you have macrophages involved, not always, but you oftentimes will have hepatosplenomegaly. They have an elevated ferritin because of the inflammation. You can have elevated liver function tests because of liver damage, and they may develop disseminated intravascular coagulation. So it's a really serious condition. Okay, so neoplastic disorders, this is just going to be the basics of it. The rest will be in the following lectures. So the different types you can see in lymphoid, you can see leukemia, and then lymphoma, Hodgkin's and non-Hodgkin's. Myeloid, you can see leukemia, myelodysplastic, and myeloproliferative. And histiocytic, the main one, Langerhans cell histiocytosis. So the interesting thing about it is that it seems like the immune system is very much prone to neoplasia. And the reason is because of class switching and somatic hypermutation, the things that are necessary for you to develop antibodies against antigens also allows for mistakes more commonly to be made. And then when you get things like that, helping to lead to translocation, stuff like that, that's what leads to neoplasia. So it's kind of a system that's, by its nature, is set up to be a potential risk for cancer. So you'll hear leukemia, lymphoma. Leukemia is usually when the main focus of the neoplastic proliferation is in the blood. Lymphoma is what's in the lymph nodes. However, there's a lot of overlap that you'll see, and I'll just show you that right here. So the top left is a leukemia in the bone marrow. So if you look at those cells, they're all basically the same type. You don't see any megakaryocytes, you don't see any red, you don't see any other things. So those are all leukemic cells wiping out the bone marrow. The bottom right, that's mantle cell in the bone marrow. So mantle cell is a lymphoma, but here it's in the bone marrow. So like I said, there's overlap between involvement of blood and involvement of lymph nodes. Another one, this took me a long time to figure out, but I put this up here. You'll hear the discussion of like blasts, lymphoblasts, myeloblasts. So these are very immature cells, okay? Whereas more mature cells, when you're talking about myelocytes, metamyelocytes, lymphocytes, things like that. So the way you tell these apart is that, so with blasts, the cell is growing. So it needs its DNA. So its chromatin will be in the U chromatin. So I know you learned U and hetero a long time ago, and probably wondering why it's important. I'm going to hopefully show you why it might be important. So U chromatin is being used, so it's more loose, whereas heterochromatin is not being used, or not being used as much, and so it tends to clump together. So the top left is, these are blasts, okay? So they have very smooth chromatin. If you look at it, all the nucleus looks about the same. That's basically the U chromatin. whereas the top right, these are mature or more mature neoplastic lymphoid cells. But you can see clumping. Okay, so this is CLL. This is chronic lymphocytic leukemia. Top left was ALL, acute lymphoblastic leukemia. And it just shows you the difference between the euchromatin and the heterochromatin, between a blast, very immature cell, and a mature cell. And at the bottom, just a comparison in the same image. Another important point with leukemia lymphoma are translocations. So a very common theme in hematopoietic pathology or hematopathology, it seems like, is a translocation. And commonly what happens is it moves a gene that isn't read as much during certain periods in life, like ones that control cell cycle, stuff like that, and it puts it next to a gene that's read all the time. And a common one is the immunoglobulin heavy chain gene on chromosome 14. So if you remember that and remember where the light ones are on 2 and 22, then that helps you know half of the translocation. And then you just have to remember things like chromosome 8 is MYC, so 814 that you see in Burkitt's is where you get translocation of the MYC gene next to the immunoglobulin heavy chain, and that's read a lot and used a lot. So that's a common theme. Then there's a general categorization of lymphoma, and then we'll go through all of these. But the stage where it's at, and then the first 4 up there are the non-Hodgkin's, and then Hodgkin's is the bottom one. I remember when I was a resident, one of the other residents called me and they said, "Well, yeah, so is this Hodgkin's lymphoma you saw?" And I'm like, "No." And then because we were still making the diagnosis, he goes, "So it's non-Hodgkin's then, right?" I'm like, "Oh," it hit me. Yeah, it's non-Hodgkin's. There's only 2. Of course, non-Hodgkin's, there's a lot of different types. But anyway, so we'll get to all these in the following lectures. So first question, so pause, answer it, and then we'll go on. So with infectious mononucleosis, we talked about you'd expect a leukocytosis, increased number of lymphocytes, and then the big one up there would be the atypical lymphocytes, which would help identify it. So, and then here's the explanation that I wrote at the time. Next one. So this one, it's describing basically an 8-year-old boy is brought to the emergency department with complaints of fever and malaise. Physical examination marked with splenomegaly, and laboratory testing shows a pancytopenia and markedly elevated serum ferritin level. A bone marrow biopsy is ordered. The pathology report notes macrophages phagocytizing red blood cells, platelets, and additional nucleated marrow cells. So this is well, it's a phagocytosis of the hematopoietic cells. And the most likely diagnosis commonly result of inherited gene defects that directly govern the function of which the class immune system. So this is the activation of CD8 T cells. So this is the hemophagocytic lymphohistiocytosis. I was stumbling on a second ago. Sorry about that. And then, like I said, the characteristic feature of this is that engulfment. It's not absolute. There are other conditions that you can see it in. It seems like we see a little bit of this on infections and things like that. But this is widespread activation, and given the fact it can cause DIC, it would be a pretty serious, potentially, condition because of that. So I'm a big fan of the concept of reflection. What it is you sit there and you stop the lecture and you think back, okay, what are 5 important points I learned during this lecture? I hope you've learned 5 important points during the lecture. And reflection is very good for cementing the material. It's a very good technique. It's in that Make It Stick. They talk about a medical student going from the bottom of the class to the top of the class. Really good. So, and then here's my kitty cat, Loki. He's bored with the lecture. I hope that you got more out of the lecture than my cat did. And thank you.